Welcome back. I'm so glad you're here to join me today. We're talking with Lajos Pustai, who is the Chief of Breast Medical Oncology here at Yale. And we're going to talk about systemic therapy. So welcome, Lajos.
Thank you, Anis. It's my pleasure to be here.
You know, we've been learning a lot about systemic therapy. Tell me a little bit more about why it's important for breast cancer patients and how you decide which patients need systemic therapy.
So the goal of systemic therapy is to eradicate runaway hiding cancer cells which may have left the breast before the surgeon actually removed the cancer. So for chemotherapy to be successful in that setting, a patient needs to have micrometastatic disease, and it has to be a type of disease that is sensitive to chemotherapy. So we traditionally estimate the likelihood that someone has micrometastatic disease based on clinical pathological variables, like the size of the tumor or the number of lymph nodes involved, and a little bit the grade and estrogen and progesterone receptor status and HER2, which are minor prognostic variables. So historically, we treated patients with systemic therapy, particularly chemotherapy, if they were high risk to have micrometastatic disease. There are various algorithms that actually can integrate these variables into a pretty reliable and validated score, or an actual percentage that a particular individual would have a 5, 10, 20, 30% risk of a distant recurrence without systemic therapy. The other component, the chemotherapy sensitivity, has been difficult to gauge or predict based on assays. However, for ER-positive tumors, now we actually have a test which is more or less accepted as a way to estimate the chemotherapy sensitivity of ER-positive disease, and that is the Oncotype DX recurrence score, and grade a little bit as well. So high-grade tumors are more sensitive to chemography, and cancers with a high recurrence score not only have a higher risk of recurrence, but they also have a higher sensitivity to chemotherapy. So that's this ideal constellation that makes this assay very useful for ER-positive disease. So a high recurrence score not only identifies the group that is likely to have metastatic or micrometastatic disease, but it also defines the cancer that is actually sensitive to chemotherapy. So that's a way how we actually, or these are the variables that we take into account when we select patients for adjuvant systemic chemotherapy. So the size of the tumor, the nodal status, the Oncotype DX recurrence score for ER-positive disease, and also other variables come into play like patient preference, comorbidities.
So how do you decide which chemotherapeutic regimen to give? I understand that there's a whole potpourri of different drugs that you can give. How do you decide which drug is the right one for a given patient?
I ask my colleagues. So that's something that oncologists oftentimes debate among themselves, and it's a constant source of academic discussions and sort of off-the-curb consultations. So there are multiple ways to approach this. One is that we would like to select the chemotherapy that's the least likely to actually have toxic side effects or side effects and adverse events in a particular individual. So we know that certain drugs are more prone to cause neuropathy, and patients who have long-standing diabetes or prior neuropathy from other reasons are obviously at a much higher risk to have this than those who don't. Some drugs like the anthracyclines can cause, rarely, but fairly well documented, that they can cause cardiovascular problems, particularly heart failure, congestive heart failure. So if someone is high risk for that, then we may have second thoughts about using a regimen that contains an anthracycline. But by and large, I think the best strategy is to try to use the most effective chemotherapy regimen that exists, that a particular individual would be likely to tolerate well. So chemotherapy regimens are historically grouped into families like first generation, second generation, third generation chemotherapy. And this roughly reflects the complexity of the regimens, the number of drugs which are involved, the length of the treatment or the intensity, and also the efficacy. So first-generation regimens are simpler, sometimes less toxic, but also less effective.
And so when people get first-generation chemotherapy, how do you decide whether they should be getting chemotherapy if they're estrogen receptor positive, or whether they should just get endocrine therapy?
Yeah.
And if they're HER2 positive, how do you decide whether they should be getting a HER2 targeted agent? And is that always combined with chemotherapy?
Yes, so you asked multiple questions. So the first one is how to select estrogen receptor positive patients for chemotherapy in addition to the endocrine therapy that virtually 99% of them receives. So the Oncotype DX test is probably the most helpful and most objective way to define this. Another way to define this is that the current NCCN guidelines call for chemotherapy for basically everybody who has lymph node positive disease. But this probably will change when the results from a large randomized clinical trial will become available that tested the value of chemotherapy for a group that may have high risk or intermediate risk for recurrence because of the positive nodes, but unfortunately also have a type of tumor that's not really sensitive to chemotherapy, and that would be the low Oncotype DX risk or intermediate low Oncotype DX risk group. So these patients probably would ultimately in the future do better with trying to maximize the efficacy of the endocrine component rather than adding on chemotherapy that really is just not working on their particular tumor. So for ER-positive patients, really probably the best way to decide this is using the Oncotype DX recurrence score. And another way to use that is if somebody has multiple lymph nodes, then you really want to err on the safe side, even if the chemotherapy is not that likely to work.
And what about HER2 patients?
Yeah. So for the HER2-positive patients, it looks like that if you compare endocrine therapy versus chemotherapy and Herceptin, the chemotherapy and Herceptin combination is more effective as adjuvant treatment. So it partly relates to the biology of the disease, that if you're an ER-positive, HER2-positive disease, it's not so dependent on ER than just an ER-positive, HER2-negative subtype. So because of that, most of the HER2-positive patients receive chemotherapy with Herceptin. A very important sort of recent development was the identification of a minimalistic chemotherapy regimen that is usually quite well tolerated. It's short, 12 weeks, and includes weekly paclitaxel along with Herceptin that produces very high survival rates when combined with the standard of care endocrine therapy for a subset of ER-positive patients. And that subset is less than 2 centimeter tumors that are ER and HER2 positive. And this particular study only included node-negative patients. And most of the patients were 65 or above. And that's actually a substantial sort of minority of the HER2-positive group. And for them, this was a really important study. So if someone is around 65 or older, has a less than 2 centimeter tumor, which very often the case with these screen-detected cancers, and has a strongly ER-positive cancer, then they actually could get only 12 weeks of chemotherapy with Herceptin. And their 5-year survival rates were well above 95%.
Wow. You know,
disease-free survival rates.
One of the things that we talked about in the course was the timing of chemotherapy, whether to have chemotherapy before surgery or after surgery. How do you decide whether patients should have neoadjuvant chemotherapy before surgery or adjuvant chemotherapy after?
So neoadjuvant chemotherapy today has two important advantages that this particular sequencing entails. One is that patients end up with a smaller surgery. So that was the initial observation that really introduced neoadjuvant therapies, that people who presented with locally advanced breast cancer were made operable by receiving chemotherapy. Subsequently, a few years ago, actually many years ago, at MD Anderson with my former colleagues in surgery, we have shown that patients, even if they are operable and present with a relatively small tumor, if they receive neoadjuvant chemotherapy, they end up with a smaller volume being resected. And we assume and we believe that that actually is beneficial because they end up with a better cosmetic outcome. The other important information that neoadjuvant chemotherapy gives is prognostic information. Patients with extensive residual disease have poor prognosis. So what is happening now, and what's really exciting, is that there are a series of clinical trials that are designed for patients with residual disease. So this really capitalizes on this observation that there are many patients who are cured with the current existing therapies. And for those, we don't really need new drugs anymore. But we can identify the group who is not having a good prognosis despite getting the best current standard neoadjuvant chemotherapy followed by whatever is appropriate because they have a high rate of recurrence. So for that group, those who actually had the best state-of-the-art chemotherapy as a neoadjuvant preoperative treatment, yet they have residual disease, they actually will have options to go on a backup sort of adjuvant treatment regimen. And what this will really be defined by the currently ongoing sort of post-neoadjuvant adjuvant clinical trials. So for triple-negative disease, currently there is a study that uses a drug that we normally don't frequently use in the neoadjuvant setting, carboplatin. So that's a clinical trial that is open already for patients with residual disease, triple-negative breast cancer, who had residual disease after neoadjuvant chemotherapy with a taxane and anthracycline. There's another study which will open shortly, which will use an immune checkpoint inhibitor in that setting. It's just approved by the NCI, and Merck will support it. So that's really a very exciting opportunity. For the HER2-positive patients, we have TDM1. So there's a large study that compares the standard of care continuing with Herceptin single agent versus giving TDM1, which has shown its efficacy and it's approved in the metastatic setting for patients who failed or progressed on Herceptin, taxanes, pertuzumab.
So for our audience, tell everybody what TDM1 is.
So TDM1 is an antibody-drug conjugate, and it's a very finicky one because it's really Herceptin or trastuzumab and the maytansine, a microtubule-binding cytotoxic drug. And it has shown improved survival in patients who progressed on Herceptin, and it's a better treatment than lapatinib or capecitabine, for example.
So that's why it's only useful in HER2-positive patients.
Right, because it's really trastuzumab conjugated to maytansine.
So the other question, and you brought this up, is the whole future of medical oncology in breast cancer and immunotherapy, which is a buzzword that we hear about all the time. And you mentioned immune checkpoint inhibitors. Tell us about the future of immuno-oncology in breast cancer.
So I think this probably will be the paradigm-shifting sort of new therapy that sort of just really hit the clinical trial phase. So there are 2 clinical trials. Both of them are phase 1 studies in triple-negative metastatic breast cancer of heavily pretreated patients. One of the studies we were involved with Merck, and another study by Genentech. And both of these studies showed a 20% objective response rate, which is actually better than what most chemotherapy drugs produce in that setting, 3rd, 4th, 5th line therapy. But the most remarkable feature of these studies was that both of them showed that those who responded had an incredibly long duration of treatment. So incredible that actually in the Merck study, the 5 patients who responded, 3 of them are still on the drug over a year. So this has never been seen before with chemotherapy. And what really makes this sort of really encouraging is that the same observations are panning out in other disease types: lung cancer, gastric cancer, colorectal cancer, a subset of colorectal cancers, bladder cancer. So this is really an across-the-board seen phenomenon that about 20-30% of patients respond. And those who respond have this really long duration. In fact, in metastatic melanoma, there are patients who, with metastatic melanoma, had participated in the initial phase 1 studies 8 years ago, and they are still cancer-free, progression-free, and alive.
And so these immunotherapies, is that really just recharging your immune system against cancer? Would you ever see a day when we wouldn't need to use chemotherapy and we can just rev up your immune system to fight cancer alone?
So like any treatment modality, how to use a new drug optimally will need to be worked out through clinical trials, and it will take, that's what's going to be really the mainstay and will occupy, I think, medical oncology for the coming 10 years. So we did this with chemotherapy drugs. We had 1 drug to begin with, and then 2 and 3 and 4 and 5, and we combined them and figured out that there is a max plateau that you could get out, and what drugs are safe to combine. So I think the same will pan out, or will play out again with the endocrine, with the immune modulating drugs. So there are several types of them, and then there is good reason to combine them with chemotherapy, with endocrine therapy, with HER2 targeted therapies. So one reason why probably chemotherapy will stay even when the immune checkpoint inhibitors become a mainstay of treatment is because chemotherapy itself produces neoantigens or releases antigens into the microenvironment that the immune system then recognizes. So you could think of chemotherapy as a priming.
Yeah, or the two may be synergistic.
That's right, yeah. So the really exciting things with the immunotherapy field in breast cancer are the metastatic studies, and it looks like if we can reproduce what happened in melanoma, that finally we can say that actually there are some patients with metastatic disease who we can keep alive for a decade or 8 years. That would be fantastic. The other exciting thing is that these drugs are moving from the really early phase 1 sort of phase into the neoadjuvant phase, with the very idea that by using chemotherapy as a priming, we can increase the complete response rates that really are associated with this good outcome by adding in and administering simultaneously the immune checkpoint inhibitors to sort of capitalize on the activity of the immune system. And the third piece is to use these drugs in the post-neoadjuvant setting or as kind of an adjuvant therapy as a maintenance treatment.
Tell me just lastly as we wrap up about toxicity and how you think in the future we're going to modulate toxicity of our regimens, because a lot of people are worried about chemotherapy because they're losing their hair and getting numbness in their fingers.
So I think the best way to actually modulate toxicity is not to give therapy. And we're getting really smarter and smarter to select individuals for treatment. So this New England Journal of Medicine paper that came out today, which is, I guess, September the 28th, 2015, have shown that ER-positive patients with a recurrence score of less than 10 really don't need chemotherapy. Their outcome is so good that they just don't need that. So it right away identifies a subpopulation who don't need the chemotherapy, so they won't have side effects. For those who need chemotherapy, I think one tendency is to really sort of identify the group where we can scale back treatment, like I refer to in the HER2-positive space, just giving the weekly Taxol along with the Herceptin so that 12 weeks is enough for them. And I think we are getting smarter and smarter in identifying the groups based on their age, their clinical pathological and molecular features, where we can roll back on the treatment. So for the other remaining group who really needs the most intense chemotherapy regimens, thanks for God, there are better drugs, palliative drugs. So we have advances continuously in antiemetic drugs. And really, emesis or nausea, vomiting shouldn't be a problem anymore. Hair loss remains an issue, and it's an issue that is very sort of hard to see how we could actually tackle other than providing psychosocial support. So neuropathy is another area where relatively little progress has been made, but there are drugs to help with the symptoms, particularly with pain, numbness. And there may be some interesting compounds that actually could prevent neuropathy, but they are in very early stages of development.
Yeah.
And of course, we can deal with the neutropenic fever by using growth factor support, which has been a mainstay of therapy to prevent this potentially really serious and life-threatening complication, which is low white cell counts and infections.
Well, it sounds like there's a lot going on in the medical oncology space in breast cancer, and tremendous advances have been made and more yet to come. So thank you so much for joining me as my guest today.
It was my pleasure. Thank you.